Thank you so much for joining us for the Kirby Institute seminar series for this World Hepatitis Week event, focused on strategies to find, test, and treat people living with hepatitis C in Australia. I think it's really exciting. The seminar has actually been jointly developed by the Kirby Institute, Hepatitis Australia, the Australasian Society for HIV, Viral Hepatitis and Sexual Health Medicine, and the Burnet Institute. And it's also, it's a great pleasure to have members from the Australian Government Department of Health in attendance as well. So thanks for everybody's efforts. My name is Jason Grebley, and I'm a professor at the Kirby Institute at UNSW Sydney. I'd just like to begin by acknowledging the traditional custodians on the lands on which we're all gathering today and pay my respects to their elders past and present. I'm currently on the lands of the Aboriginal people of the Eora Nation. I'd just like to also extend that respect to Aboriginal and Torres Islander peoples that are joining us today. So I just want to sort of emphasize that you can ask questions throughout by clicking on the Q&A icon at the bottom of the screen. And look, I guess just to sort of state that we're at a really exciting time. Australia has committed to eliminating Hep C by 2030. We've got a range of targets to increase diagnosis and treatment and reduce the number of new infections and liver-related deaths. I think the new therapies were an amazing advance, and also we've now got new diagnostic strategies that we can implement. I think our ability to achieve the WHO targets in Australia is being threatened by declines in annual testing and treatment. And so really, we brought this seminar together to try to discuss some of the ongoing efforts. And this will also include a panel discussion at the end. So I'd just like to start by I'm going to introduce all the speakers now, and then we'll just transfer through just for efficiency. So first, we'll have a statement from Stuart Manoj Margison, who's the Director of Bloodborne Viruses, Sexually Transmitted Infections, and Torres Strait Islander Health Policy Section at the Australian Government Department of Health, followed by a presentation from Kerry Fowley, CEO of Hepatitis Australia. Then we'll move on to Emily Adamson, who's the Health Promotion Program Manager at EC Australia, and Troy Combo, the Program Manager for EC Australia Partnership at the Burnet Institute and also at the School of Public Health at the University of Queensland. Then I'll present something, and we'll move on then to Shelley Kerr, who's the Hepatitis C Program Manager at the Australasian Society for HIV, Viral Hepatitis and Sexual Health Medicine, also known as ASHM. And then lastly, we'll move on to Greg Dorr, who's a professor at the Kirby Institute and UNSW. Then we'll be followed by some questions and panel discussion, sort of the most exciting bit. And we really encourage you to put questions in, because I've got some questions, but would be great to have some audience participation. So without further ado, I will hand it over to Stuart to say some opening words.
Great, thank you, Jason. Good afternoon, everyone, and thank you for the opportunity to be part of the webinar today. I too would like to acknowledge the traditional owners of the lands, and for me that's the land of the Yorta Yorta people, and to pay my respects to elders past, present and emerging, and acknowledge any First Nations people that we have participating in the webinar today. So my topic is moving towards hepatitis C elimination in Australia, and I think the move towards elimination happened the start to move towards elimination happened some time ago. We're well on our way. We got off to a roaring start in 2016 when the DAAs were added to the PBS, and saw that we were treating over 1,000 people and curing over 1,000 people every month on month. But the warehousing, in inverted commas, effect has worn off, and we've seen a bit of a deceleration since then. We also acknowledge that the closer we get to elimination, the more difficult it's going to be. And it's going to be harder and harder to find and engage the people necessary to test, treat, and be cured. So we need to build on the learnings and achievements over the past decade and develop new approaches. We need to continue to learn from our communities and listen to the voices of lived experience and how we can get our services to reach them. And we need to come together across all levels of government, community services and research to maximise the efforts through collaboration, integration and sharing to make sure that we are achieving the targets in the cascades of care. So out of these needs, I guess, was born the 50,000 project last year as the way to accelerate our efforts and meet the elimination targets as set out in the fifth National Hepatitis C strategy, 2018 to 2022, and perhaps more importantly, to meet the actual elimination goals of 2030. And I don't want to steal anyone's thunder, but echoing Jason's words, it is very exciting. And I find it somewhat humbling to see so much activity happening in the viral hepatitis space right now. I mean, World Hepatitis Day, it seems like we have a week's worth of events to celebrate and mark it's important, which is just, it's wonderful to see. So I think, and I know I've gone on record to say this before, that our response is underpinned by a partnership approach between government, community orgs, people with lived experience, and researchers, and the sense of shared responsibility and effective partnerships are two of the guiding principles of the current strategy. And I think today provides a great demonstration of these principles in action. And the 50,000 project is an embodiment of the benefits and achievements that can occur when everyone comes together as one. I didn't think I could present on a World Hepatitis Day webinar and not take 1 minute to provide an update on the development of the next iteration of the strategies, because they're such a key driver in keeping us moving towards our elimination goals. So all of the bloodborne virus and sexually transmissible infections standing committee members have provided input, and that's allowed us to develop a first draft. And the department's currently at the final stages of seeking approval to commence a targeted consultation on that first draft. I expect that will happen very soon, and it will happen over a 6-week period to make sure that engagement is meaningful. That feedback will give us then a penultimate draft, and we'll take it from there. So what I wanted to finish on, and I think probably for me make an emphasis on, is the thank yous. And sort of Jason's introduced everyone, and we're about to hear from everyone in terms of a range of speakers that are all contributing to the elimination effort. There's so much hard work, so many clever and dedicated people, and so much goodwill that I wanted to sincerely and wholeheartedly thank you all. Jason and to Kirby for organising the webinar and the delivery of the point of care network across Australia, Carrie and Hepatitis Australia for the national information line and the Ending Hepatitis C campaign, Emily, Troy and EC Australia / Burnet for the It's Your Right campaign, Shelley and the ASHM crew for Beyond the Sea, Penny and Shweta at the department for their tireless coordination and administration that goes on behind the scenes, and then everyone else who plays a part and who is part of this webinar today and participates in the events over the week. I'm very proud to be part of this wonderful partnership. Thank you, and I think I'm handing over to Carrie.
Lovely, thank you, Stu. Hello, everyone. It's so nice to be here. I'm joining you from the unceded lands of the Ngunnawal people, and I pay my respects to elders past and present. Thank you for this wonderful opportunity to have an event on the eve of World Hepatitis Day. Building on the thanks from Stu, I'd also really like to express gratitude to people with lived experience of hepatitis C and how much they've really driven the success in prevention, harm reduction, treatment, testing, and it's through their efforts in partnership with so many people here today and to public health that we can realise our elimination goals. And so I guess building also on what Stu's saying is that this event is really coming at a critical time in our elimination journey. It's so great to hear, Stu, that the National Hepatitis C strategy will be out soon for consultation. I know we can't wait to get our teeth stuck into the next stage of the process and to work with so many people to make this really critical document the best it can possibly be in the service of the communities. Critically, the strategies that are due to extend to 2030. and really provide a pathway and a vision for us of all the work that we can do together across prevention, treatment, harm reduction, and care. And affected communities really deserve and should expect to be rightly placed at the centre of these responses, not just as patients or clients, but as partners in the national response. And it's so great to hear the emphasis from the Commonwealth about how partnership is central to the success to date and will be critical to going forward. So I've been asked to reflect on some community-led efforts in terms of finding, testing and treating people living with hepatitis C. So first, I just want to share some high-level reflections on the framing of testing and treatment. So clearly, these interventions are critical, but they're not the whole story or the whole response that's needed. And I know lots of people know this in the room, but it's important sometimes just to reflect on that. And when we think of the national strategies, including when we report on them and our implementation of them, we often limit our assessment to just the targets, but there's so much more to these strategies than just the targets. Like the turtle nerd that I am, I carry around my hard copies of the strategies with me most of the time to remind me of the goals and the principles and the priority populations and the targets that are within there, because as a body of work, they're really rich in terms of being able to drive a whole bunch of interrelated action. And I guess one of the key things in that is to make sure we think of the whole person and think of their whole life course and their context and their needs. So also you may have noticed in some of the things I've been saying so far is I've also been highlighting prevention and harm reduction and care in my comments, and that these need to go hand in hand with testing and treatment. And that's because our partnership with affected communities, it needs to include this broader spectrum of the needs of the people. And also, I guess, to recognise that for some people that have been treated for hepatitis C, hepatitis C doesn't end at the cure necessarily, but the impacts remain, be them legal, be them health, but our cascades of care do end at that point. So that's, I think, something for us to think about. And I guess for Hepatitis Australia, and I know other community stakeholders, we're really determined to make sure that prevention/harm reduction, in particular high-risk settings such as prisons, is much more stronger and more explicitly stated, including the need to implement sterile and regulated sterile and regulated injecting equipment within prisons. And also that we need to think more about sub-targets for late diagnosis for both Hep B and Hep C. So also, I guess a key thing as well is about working from a place of equity and ensuring that our national strategies and our response responds to the needs of the people, not the other way around. Otherwise, we'll risk leaving people behind. And that applies, for example, geographically as well. So we know that people in regional areas, for example, do not have the same type of access to services and interventions that they may need, and that we need to make sure that our responses are being spread to all the people that are affected. And then also, I guess, to expand into, I guess, non-traditional hepatitis C settings and spaces where we might have, I guess, more low prevalence hepatitis C. And so a lot of this is because of the success to date. We need to spread out into other spaces and form partnerships with other communities, other sectors, other things to ensure that we can test all the people that are needed and engage them in care. And so I guess a lot of people as well, might not currently identify with risk behaviours. They may have contracted hepatitis C a long time ago and may have been half diagnosed in an era where treatment was less favourable. And so for these reasons, they're effectively lost to follow-up or not diagnosed, and we need to find them, and we need to find them again and really engage with them and explain how things have changed. And so another is, I guess, the spectrum of testing options that we need available to be able to mobilise our response as best we can to where people are. So the way that point of care sits across the spectrum of testing, that would also, for example, include self-testing options to be able to get things into people's homes where people might not be prepared to come into more traditional health services. And also, I guess, the critical role of the community workforce in this, who is just so well placed to be able to get into places and spaces where different communities are, and the importance of resourcing the community workforce to be able to just do that. So I guess just building on also comments from Stu about the 50,000 project, this is such a great example of partnership, of what makes this space so special is the way in which people work together to identify problems and solutions together. And it's going to be so great to hear for the rest of the forum about some of the activity that's happening with that from both Troy and Emily and Jason and Shelley. So all the pillars across the 50,000 project are mutually reinforcing and interrelated, and looking to amplify their reach and reinforce messages and outcomes, because it's been acknowledged that the business as usual, I guess, approach is not sufficient for all of us to reach our goals. So we need to make sure we've got the resources and capacity across the spaces for people to do the work they need to do. So in closing, I'd really just like to wish everyone all the best for World Hepatitis Day. It's so exciting tomorrow. So usually Federal Parliament never sits in July. I did a Google earlier. The last time it sat in July was in 2012. And we're so pleased that tomorrow, in the first sitting week of the new Federal Parliament, will mark World Hepatitis Day. And that'll be marked by people wandering around with Hep Can't Wait badges like this, with a parliamentary roundtable and also a reception, and all in honour of people with lived experience of viral hepatitis, which is just wonderful. And World Hepatitis Day, it's such a wonderful opportunity for all of us to stand arm in arm and be louder together. Thank you.
Thanks, Carrie. Thanks, Carrie, for a broad overview. And thank you to everybody who's organised today. It's great to be here based on the partnership approach of all the work that we're carrying out. I'm just going to share my screen. Please let me know if it doesn't work. So I'm Emily Adamson, the Health Promotion Program Manager for EC Australia. And today I'm going to be focusing on the Ichiro Right campaign and how we're rolling it out across Australia. So first off, I'd like to acknowledge our support, which has really supported the development of this campaign and the rollout. So first off, I'd like to acknowledge the Paul Ramsay Foundation, which has funded the Eliminate C Australia partnership, also known as EC Australia. And I'd also like to acknowledge our partners and supporters, the Australian Government Department of Health, which is rolling out the National 50,000 project across Australia. So the Ichiro Right Health Promotion Campaign, it's a campaign that's been built to increase testing and hepatitis C treatment in people who inject drugs. So with the campaign, we wanted to reach people who are not accessing testing or treatment, and we wanted to shift perceptions around treatment, but also to support people who inject right through the testing process and through to starting treatment. We set up a national reference group, and so EC Australia, together in partnership with ABLE, have led this reference group, and we've co-designed the campaign, and we've really used a peer-led approach to our co-design, and we've focus tested all our campaign messages with people who currently inject drugs, which I'll be talking through in a moment. So I just want to spend some time talking about what the campaign is. We've got quite a few different strategies and they all interact with each other. So first off, we've got paid street advertising, and this is about prompting people who inject drugs to think about Hep C treatment in a different way. We've got funded peer outreach engagement activities, and this is about increasing conversations about hepatitis C and also links through to trusted services in different areas. We've developed quite a bit of merchandise, and this is about giving it away to spark conversations with people who inject about Hep C testing and treatment, but it's also consistently promoting our campaign messages as well. The campaign also features financial incentives. So this is about giving a financial incentive if someone comes in for testing, or perhaps they refer one of their friends to come in for testing, or if they do test positive and they start treatment, they can also receive an incentive through that treatment pathway. We've got a great campaign website for Ichiro, and we've got some fantastic short films where we have 3 people sharing their personal story of going through the treatment. So I'll be highlighting that campaign website later on too. And lastly, the Ichiro campaign is really about localised referrals. So we want to connect people with a local peer-led drug user organisation and also nearby treatment services. So at the moment, the Ichiro campaign is rolling out across Australia, and we're using a staggered launch approach. So what this means is we started back in April, we had our first launch, and that was with 3 different jurisdictions. And we've staggered our launch all the way through this year. So we've started with NT, South Australia and Queensland. WA and ACT are active right now, and we're soon to kick off with Victoria and New South Wales and Tasmania. So the campaign's a 3-month burst of activity, which is quite intense with the combination of strategies that we have. And I just want to note, it's not a statewide approach. So we're really localising our activities, and that's around the drug user organisations and the way that we're referring people through. So you can see here our great list of partners that are helping to roll out the campaign. And it's all linking people through to the peer-led service. And in Tasmania, we're using a slightly different approach where we're linking people with a local NSP service. So I wanted to show off our campaign resources and products. These are our key messages that we're using for the campaign. These messages are used in our paid advertising, which features things like buses, shopping centres. We've got posters in local NSPs that have peers. And also we've got posters in supporting services where we know people who inject are going to and accessing a range of different services. So you can see the campaign's vibrant and colourful, it's empowering and it's communicating trust. And I also wanted to note that our messages are addressing the misconceptions around Hep C treatment for people who inject. So particularly we know that a lot of people don't realise that they can get treated by their using, and also that they can get treated more than once. Here's an example of our Aboriginal burst of advertising, and Troy Combo is going to go through this in more detail. Again, we needed to reach our audience. So we've just come out of a co-design period with our Aboriginal peer group co-designing these resources, and they look fantastic in the public spaces, and we're getting a lot of good feedback about these messages. So I just wanted to show off the campaign in action and what the advertising looks like. So on the left, you can see our posters on vending machines up in Northern Territory. We've got advertising at local train stations. So that's a great example of Brisbane train station. We've got our messages on buses travelling around South Australia. So it's quite a wide range of channels that we're getting our advertising in. In the middle down the bottom, you can see our Aboriginal burst of advertising travelling around the east coast of Queensland, and it looks fantastic. And in your bottom right, it's a really nice photo of what it looks like in a local NSP up in Northern Territory. We're also promoting the campaign through social media. So here's 2 great examples. A local pharmacist has popped up our posters in Coolangatta, and Quinn have done a lovely social media post promoting the campaign. And on your right, you can see NTARC in Northern Territory promoting the videos of personal stories about Hep C treatment as well. So I just really want to highlight the campaign is about promoting Hep C treatments and promoting information about Hep C treatment to people who inject, but we really want to go beyond just raising awareness. So our campaign strategy is to address the stigma and discrimination that goes alongside with injecting drug use. We really wanted to match the advertising messages with peer-led activities, because we know that peers working on the ground and talking to people overcomes that distinct stigma and discrimination that goes along with hepatitis C as well. So the peer-led activities are really about increasing conversations and linking people to care. So we've got things like barbecues happening in different areas, peer-led point of care testing, also peers working in mobile vans to reach people. And we've also linked the incentives to peers. So if someone comes in for testing, they can get an incentive that's given out by a peer. And this kind of really contributes to that positive health experience and overcoming the discrimination that some people have previously had. And lastly, we've got the call to action that's referring people through to their local peer organisation. So just quickly, just to finish up with, I just wanted to share some reflections of what we're learning so far with the campaign. It's a little bit too early to assess the impact of advertising, but we will be doing this with some evaluation down the track. But partner organisations have really embraced the vibrant campaign, the products, and also their approach of peer outreach and incentives. We're getting a lot of good feedback that the posters and the t-shirts, the merchandise, are sparking conversations, and that's what we really wanted. It's giving people a new energy to talk about hepatitis C treatment. And really, look, the tailored approach that we've used in each jurisdiction has meant that the drug user organisations are reaching different spaces. So they're trying something different to the usual approach, and they're amplifying what they already currently do. And lastly, I just wanted to note that the funding really has been essential to support that peer outreach, and that's something that we'd need to keep amplifying if we carry on with the work of the campaign. Just quickly before I finish, I wanted to acknowledge our wonderful partners. It certainly has been a strong partnership approach to roll out, but to also design the campaign. And I think the peer-led approach has been really a significant reason for the energy of the campaign and the success of getting the messages out there. So thank you. And now I'm going to hand over to Troy Combo, who will talk through another component of the Ichiro campaign.
Thank you, Emily. I'll just share my screen and get my presentation prepared. Thank you, and thank you very much for the introduction, Emily. Just like to introduce myself, Troy Combo. I'm the Aboriginal Program Manager for EC Australia, and I'm based here at the University of Queensland. So I'd just like to start by acknowledging country and pay my respects to elders past and present. And I'm zooming in to you today from the land of the Turrbal and Yuggawal people here in the Greater Brisbane region, otherwise known as Meanjin. So just quickly, I'm going to flip the presentation a little bit and just talk to you about how we sort of pivoted halfway through last year in response to some feedback from testing our campaign messages and assets with peers that were accessing the partner organisations that Emily has introduced to you today. What we found there, we had around 23-25% participation of Aboriginal and Torres Strait Islander people complete the survey. And a lot of them were saying that the messaging resonates with them, the call to actions were fine, but they would really like to see some Aboriginal artwork and cultural branding that would really, I guess, capture their eye and talk to them and represent Aboriginal people within these services. So we quickly convened a working group with Aboriginal peers, and I'd really like to acknowledge the input that Colin Michelo from the Institute of Urban Indigenous Health, who was a previous peer worker at Quinn in Queensland, also Yemi Forrester from NTAC in the Northern Territory, and also John Vandenduggen, who has joined us from Hepatitis ACT. The work they've done was unbelievable. It was quite a really quick turnaround. We engaged with an Aboriginal-owned design agency. They were called We Are 27, and they developed the concepts and the artwork in quite a tested environment online over 8 to 10 week period. We had quite intense meetings weekly, and through the workshops we came up with 2 initial concepts, and these concepts are very strength-based approaches, and one is utilising bloodlines and I guess the importance of kinship, and the other was keeping country strong. When we went to some further testing and worked with the peers, we came up with a consensus to go with the sign of bloodlines, and that really fitted in a lot better with the overall campaign of the Ichiro and what we're trying to do in eliminating hepatitis C. So Ricky Salam from We Are 27 went back and developed the thematic artwork that represented the bloodlines theme. As you can see here, we to get the themes, we used online word clouding. And as you can see there, we had 5 questions. What words that describe family, words that describe health, words that describe culture, words that describe country, and also what colours do you think would connect to this campaign? I'd just like to say I have a default of when asking, to describe family, I'll go to a strength-based approach, but working with these peers really highlighted some of the challenges that the people that we're working with have. And we came up with words such as loud, hectic, pressure, pain. And I think that was really, really useful and really important to have them types of word coming through there as well. You can see the larger words there. They are the words that were used more often or were had multiple inputs. So the more common a word was put in, the larger the word was. And that's how we sort of came up with the examples of the themes. So once we developed the themes and we developed messages and the calls to action, we then went back and done an online service. So we retested the messages again with some new introductions, working with the peer group. And we also wanted to ensure that these new messages resonated with Aboriginal audiences. And through this, we had all state and territories participated, barring ACT and Tasmania. And the purpose of this was to capture what appeals to our audience, explore language and identify our messages are meaningful, and assist in introducing new messages into the campaign. So we had a really good uptake of respondents. We had 87 of the 92 respondents completed the survey. 83% of these identified as Aboriginal Torres Strait Islander, and you can see the breakdown by Aboriginality there in the brackets. We did remove the non-Aboriginal patients from the survey analysis, and these were the people that identified that completed the survey. So 69% of them identified as people who injected drugs. We had some peer workers. We also asked people if they'd been treated. 31% had said they'd never been self-reported that they'd never been treated. 24% had currently or had been treated. And we had very small numbers of health and community workers and other not stated there. So the first campaign burst, we took the existing messages and calls to action to catch up with the first campaign burst in Northern Territory and Queensland and South Australia. And we released 4 posters here. And as you can see, the messages and also the calls to action that are on them. And they're very focused towards the peer user organisations as the campaign outlined. We came back after testing and after the analysis, and we found these were the 4 posters that would go to for the future rollouts in the burst 2 and burst 3 of the campaign. And these are the 4 posters that have come through for street advertising messaging. And we've also got the 4 posters that will be used for advertising within the NSP settings as well. What did come through is that less words are better for these campaigns. And if you would like to get in touch with us, we have a further analysis and some further outcomes from what people had to say around the testing of these resources as well. So I just wanted to finish just on some, and I know Emily showed this one, but I really wanted to show a mobile billboard that's been around the Brisbane and the Gold Coast area and the Sunshine Coast. And one of the beauties around this was that when they painted this billboard, it was painted in a public space. So people were able to watch this message come to life. And it did, I guess, initiate conversation within the wider community as well. Feedback that we're getting from Isha down there in the Quinn office on the Gold Coast. Part of getting the message out there in the artwork, we thought it'd be useful to have a postcard size, postcard of the artwork, but also what the message meant from the artist. And Ricky wrote a really comprehensive, breakdown of the motifs that are used and how that attached to Aboriginal community and the bloodlines that were used. So future work to happen in this space, with additional funding from the Department of Health, with Stuart and Penny and Schwetter and the team. We're going to just about to commence a national hepatitis C health promotion campaign that will have a focus towards the Aboriginal community trial health organisations. We are working in close collaboration with NACHO on this, and we're just about to send out expression of interest to convene the national reference group. We're looking for opportunities where we may be able to link the Ichiro campaign into the ASHM campaign, and be looking to use the artwork and some of the messages, and building on the strength-based bloodlines theme of some feedback we're getting, as you know, about let's protect bloodlines, get treated, Ichiro and that type of thing. So we'll do a rapid design phase over 4 workshops. We were looking to engage an Aboriginal facilitator, and I think from what we've learned from this is that having Aboriginal-led design agencies and Aboriginal-led reference groups, that we really come up with products that really resonate with the audience that we're targeting. We want to explore if resources will need traditional place-based languages. It's something that did come up within Northern Territory, but we just need to explore that a little bit further, especially with the dissemination of this campaign into more regional and rural and remote areas if needed. So there's also going to be a suite of the current resource campaigns adapted for the rollout in the Kirby point of care testing machines, with the 10 ASHMs that will be participating within that program as well. So outside of that, we're also starting to find we are getting really good feedback and a lot of requests for these resources to be used within the ASHM sector. So I think it's quite timely now and quite urgent that we get this national health promotion campaign underway and done as expeditiously as we can for the ASHM sector. And thank you. And I'm passing back to Jason, and I will just stop sharing my screen. And
Troy, do you want to stay on for a quick sec? I'm going to go off script here.
Okay.
And just for people who don't know, Troy let us know he has a plane ride to catch to get down to the event tomorrow. So I just don't want you to be stressed about catching your plane. So I thought I'd just ask you a question here to engage you in the conversation, Troy. Look, I was just wondering, could you elaborate a little bit more about what you think needs to be done and how we might need to modify our approaches to facilitate increasing awareness, testing, and treatment for Hep C among Aboriginal and Torres Strait Islander people? So maybe beyond the It's Your Right campaign, which you guys have done like an amazing job with, but do you have any sort of outside the box ideas that we need to be sort of exploring or thinking about, and how we might approach things slightly differently to start those conversations?
Yeah, Jason, look, I think more downstream, I think, you know, there's really good opportunity to partner with local Aboriginal communities. I think from what we've seen from the development of the It's Your Right campaign, having Aboriginal-led solutions, I think will go a long way. So I think, you know, ECA, we're partnering with Bulgaroo and ASHM to do a workforce development plus a CQI and testing and treatment campaigns as well. So I think having that locally led solution-based approach, I think will really go a long way. Obviously, we need to resource, you know, not only just funds, but staffing as well for this to happen, and ensure that, you know, also that the workforce is, you know, trained up to be able to address hepatitis C in their communities.
Well, that's awesome. Okay, well, thanks so much, Troy, and fantastic presentation. So if you need to drop off to catch your plane, you know, whenever you need to, feel free. But yeah, thanks so much for your time.
Thank you, Jason. Thanks, everyone.
All right, so on to me. So again, I just wanted to sort of reflect on Stu and Carrie's comments. I think it's such an exciting time. And I think one of the reasons it's so exciting is how much energy there is in the sector right now. I don't know if I've ever seen it like this before over the sort of 15 years I've been sort of in the field. And it's just so exciting. So I just would like to thank everybody and hope we can continue that enthusiasm over the next couple of years. So I'm going to be speaking around enhancing testing and linkage to treatment, and with a bit of a focus on the National Point of Care Testing Program. Before I start, I just think it's really important to acknowledge how big of an effort this is and some of the work that's ongoing. In particular, I would like to thank Flinders University and the folks at the International Center for Point of Care Testing, in particular, Sue Matthews and Corey Marcus and the whole team there. And also the Australian Government Department of Health, who funded the National Point of Care Testing Program, and just all of the services and partners and community orgs. You know, this is just, it's been so amazing, the sort of excitement around this, so thank you. Many of you seen this slide before, but just to set the scene, you know, I think we're all aware of the long journey to an HCV diagnosis with sort of conventional testing pathways, having to get an antibody test first, and then, you know, it's great if you have on-site phlebotomy, but if you don't, you have to send somebody off-site. Then you get your antibody diagnosis and you have to do an RNA test, again, potentially having to send someone off-site, and then, you know, initiating treatment. And look, I know in the majority of settings that's been streamlined and probably, you know, comes down to maybe a 3-visit model. But irrespective, there's places along the cascade where we can potentially lose opportunities to engage people in care. The focus of the talk's about point of care RNA testing, but I really want to ensure that, you know, I think we need to have a suite of diagnostic testing tools, and point of care RNA testing is not the only solution. I think one option, if we want to think about how do we compress things down to 2 visits, is reflex RNA testing. And there's a recent roundtable discussion around this. And I think that it's not simple, but there are ways that we could better integrate this into standard of care, so that we collect 2 tubes of blood, and then what you would do is you would do an antibody test on the one sample, and then if it's positive, you would then do the RNA testing on the second sample. And I think there's already labs that are starting to do this and GPs that do this. So it's a bit of education on the GP perspective that you can do this multi-testing ordering, but then also at the labs, getting some labs on board with collecting 2 tubes of blood. I think rapid antibody testing is exciting. We don't have an approved rapid antibody test in Australia that's TGA approved, but again, that's a way that you could get to 2 visits, even if you don't have point of care testing, to do the rapid antibody test. If it's positive, you take a venipuncture sample and then send that off to a central lab. So then I think we really, you know, I've been so excited and fortunate to be involved in the New South Wales dry blood spot testing project, which is being led by New South Wales Health and St. Vincent's Applied Medical Research Centre. And, you know, this is another option, gets rid of the issues of venipuncture, which we know among some people who inject drugs have poor venous access. So being able to get a finger stick of blood, you can dry it, it can be stored easily, you can test other things for it. So there's lots of advantages. But with all of these, it still means that you have to come back for a second visit. So that's the one place where I think point of care testing offers an opportunity. So enter in finger stick point of care testing. This is the Gene Expert. Many of you have seen this slide before. This is the cartridge, and this is what a 4-cartridge machine looks like. And this is Francois Lemery, who's actually now with Cepheid, but used to be with our group doing testing up in Cairns with Cairns Sexual Health Service and the team at the NSP up there. So I really think that this is a massive game changer by the availability of a test that can detect active infection in an hour. We can really do single treatment and single visit treatment, and that increases testing acceptability without having to have venipuncture, and potential to reduce loss to follow-up and potentially address this issue around the care cascade. I think the other thing is, like, it's a mini lab, very, very good sensitivity and specificity. So yeah, I just thought I'd run through again. Some people have seen these slides, but some haven't. There's a partnership project with Kirkton Road Centre and NUA and ourselves, looking at a community-led needle syringe program in Sydney. Participants were offered Gene Expert testing. Those that were positive were then engaged in peer support from somebody with lived experience. And anybody who was tested was fiber scanned, and in people that had current infection, point of care testing for HIV using the Alere combo assay and Hep B. Pretty marginalized population. Everybody had injected in the past month, 18% greater than daily. And I think what was impressive is, of the 100 or so people tested, there was 27 positive, but the treatment uptake was nearly 80%. And so if you compare that to Greg Doors led some work with others looking at treatment uptake among people with diagnosed infection in New South Wales. And if you look at people with history of opioid agonist treatment, or people that were injected for were hospitalized for an injecting related infection, the treatment uptake was 27%. So compared to sort of standard of care in a similar population, quite an impressive jump. The other thing is that we weren't sure how many people would actually initiate treatment in the same visit, and pretty impressive, just over 50% initiated treatment in the same visit. I think 95% of people initiated treatment in a couple of days. Just another study just to quickly show is some work that's been led by Andrew Lloyd and Yumi Sheehan, who's been doing all the hard yards. Participants were recruited from a reception prison on the mid-north coast of New South Wales, and there's a control period, 240 participants enrolled, and then an intervention phase. And this intervention consists of point of care testing, a survey, clinical assessment, and a fiber scan with fast-track DAA treatment initiation. And so if you look at the standard of care group of the 240 that were enrolled, just under 50% had ever injected, 18% had ever received any sort of HCV antibody or RNA testing, and 26% of those positive initiated treatment. And that whole process took about 90 days. And then enter in sort of the one-stop shop approach. So of the 300 or so enrolled, 42% had ever injecting. Look, not surprising. If you offer testing to everyone, you're going to see an increase in the proportion tested. But I think what was remarkable was the increase in treatment uptake. So from 26% to 93%. And that whole process took 6 days instead of 90 days. So, a big, shout out to Yumi for all her hard work on this. It's a really nice study, and hopefully provide some evidence moving forward. So look, if we think about single visit strategies to improve testing, I think obviously if you're in a high prevalent setting, you could go with sort of point of care RNA, immediate point of care testing. That makes sense. But the question is, well, and how do you define low? But in a lower prevalent setting, would it maybe make sense to use a point of care antibody test? And then in the people that are positive, you would then reflex the point of care RNA test. So, if you think about it, well, why might that be optimal? Well, first of all, point of care RNA testing is more expensive than antibody tests. So it's about $60 a test versus $10 a test. The other thing is that there's a longer time to result for a point of care RNA test compared to a negative antibody test. So the specific assay we're using right now is the Abbott BioLine HCV assay. And for a negative test result, it's 20 minutes and then 5 minutes to a positive. So it actually doesn't add too much to your clinical visit. You can actually do a 5-minute test and then you do the point of care RNA, but it allows the people that are negative to not have to sit around for an hour for their results. Also, for blitzes or campaigns, it might improve the efficiency of the gene expert. So you can only do 4 tests per hour with a 4-module machine. But if you actually think about it, if you were to sort of do testing blitzes and use the antibody screening, let's say you have 10 people that you test, 2 are positive, it actually increases your throughput to be able to do 20 people in an hour versus only doing 4. So I think that's another potential opportunity. There's some work that we've been doing, and this has been led by Sophie Shih at the Kirby Institute, who's a health economist. And what we've been doing is looking at the cost effectiveness of different point of care testing strategies. So what we did is looked at different settings using real world data in the prison, needle syringe programs, and drug treatment. And here's the sort of results that I showed you before in terms of the point of care testing outcomes. And we now have reasonably good, this is from the Pivot study in terms of the standard of care outcomes. And I mentioned the data from New South Wales around standard of care and other settings. Now, if you think about it, so if you take standard of care testing, here's the figures for all of them. I think the point to make here is that irrespective of the point of care testing strategy, point of care testing, if you look at the cost per person treated, and this is driven by an increased treatment uptake that you can get with point of care testing, point of care testing leads to about a half, at least in terms of the cost compared to standard of care. And that's all driven again by the treatment uptake that you get, even though the cost as a package is more expensive per test. So I think that's sort of the first point to make. The other thing is the question is, well, what antibody prevalence would you use point of care RNA testing versus antibody testing? And Sophie's done some really nice work, and it was much higher than I expected. But essentially, if the prevalence of HCV antibody prevalence is above 74%, then it makes sense to use a point of care testing strategy for all. But actually, if the prevalence is below that, if you use combined point of care antibody and reflex RNA testing among the positive people, then that's the best strategy from a cost effectiveness perspective. And actually, if you take into consideration their previous treatment history, that actually improves things even further. So if somebody's received treatment, there's no point in doing an antibody test. You might as well just do an RNA test. So again, I think this is where we're moving forward. I think we'll continue to evolve, but I think getting a bit smarter with our testing strategies. And we did just put in an MRFF grant to sort of evaluate this as part of the national program. So just in terms of the national program, so 85 sites nationally, plan is to test 50 to 60,000 people over the next couple of years. We've now got 85 sites selected. But this is across a range of different settings, and a lot of places are testing at multiple different sites. So it includes drug treatment clinics, needle syringe programs, prisons, mental health, mobile outreach models, homelessness services, Aboriginal community controlled health organizations. And I'm really proud to say that we've got about 10 Aboriginal community controlled health organization sites. And so testing is pretty broad. Anyone at risk of HCV are attending that service, and the program includes standard operating procedures, logistics, deployment, setup, training, quality assurance program, and look, really excited to be working with Flinders and the International Center for Point of Care Testing. They've just been doing a really amazing job with the training, and also with NRL around the quality assurance program. And we've got IT connectivity systems that have been set up, and a research evaluation framework through an NHMRC partnership grant that's recently been funded. And this is just an illustration of some of the materials. And here's a map of sort of where the sites are located. You can see they're predominantly in urban areas. And we are offering point of care antibody testing through a research related funding. And so we really need to get TGA approval of that assay, which the manufacturers are working on. Okay, so just in terms of a program update, so there's 16 active sites, 38 operators have received training so far, that might even be higher over the past week. And just over 1,700 people have received point of care testing now to date. So just over 1,600 with RNA testing, and almost 120 receiving antibody testing. And really quite a large number of people with current infection identified, so 360. And I must say that that's been driven primarily by a series of prison blitzes, but led by the Combi Clinic and other Queensland partners. So a blitz that was led a couple months ago in Woodford, north of Brisbane. So 673 tested, RNA prevalence was 27%, but really amazing what the team was able to achieve. 90% of people had treatment scripts written by the end of the sort of campaign. And then Barallan, which is sort of west of Brisbane, 358 testing, quite a high prevalence, 39% RNA prevalence. And they've now written scripts for 100% of those people. So really amazing what can be achieved. And look, I just got to thank Mim and Joss from the Combi Clinic. They've just been amazing collaborators and have really contributed, I'd say probably 75% of the testing that's been done so far through the blitzes and through the collaborations that they've made. And I just think that illustrates that collaborative nature of what's going on right now. And it's just really exciting moving forward. And I guess just ending on that, thank you so much to all of the partners and collaborators. It's just been a really amazing journey so far. So I'll stop there and pass over to Shelley. So thanks.
All right. Thank you, Jason, and everyone, all the other presenters. It's really great to be here today with all of you. My name's Shelley Kerr. I'm the Hepatitis C Program Manager here at ASHM, and today I'm joining you from the lands of the Ngunnawal people, and I'd like to pay my respects to elders past, present and emerging. For those of you who may be less familiar with ASHM, we're a not-for-profit peak organisation committed to the elimination of hepatitis C and other bloodborne viruses as a public health threat, and promoting the sexual health of people in Australia and across our region. We support members and health professionals working in the HIV, viral hepatitis and sexual health sector through workforce development activities such as education and conferences, guidelines and resources, as well as policy and advocacy. Today, I'm talking to you about Beyond the C, hepatitis C elimination in your practice, which we believe will contribute to finding those who've been lost to follow-up and link them into care and treatment in the primary healthcare setting. So first, I'd like to acknowledge our generous sponsors, so Gilead Sciences and EC Australia, who funded the pilot program, and the Commonwealth, who are funding the implementation program of Beyond the C. I'd also like to acknowledge the steering committee and the pilot project team, Ros Rolliston, Liv Dawson and Melinda Hassel, for their contribution to the success of Beyond the C. So I'll begin with an overview of the pilot program, which was conducted between 2019 and 2021, and share some findings from the project, and then I'll provide some insight on how those findings have informed the National Implementation Program. So Beyond the C is a comprehensive and incentivised model of virtual practice support to facilitate active case finding, screening, testing and treatment of hepatitis C. Utilising a whole of practice approach, the project provides primary care practices with tailored support, education, resources to implement case finding and quality improvement activities to enhance hepatitis C care. The aim of the project is to embed sustainable QI skills into routine practice and increase the number of people identified and recalled for screening, testing and treatment. Practices were guided by our general practice nurse consultant, Ros Rolliston, to utilise their medical software system for case finding, auditing and quality improvement. Project development commenced in September 2019 and recruitment commenced approximately 1 year later. Project development was an iterative process and the original ideas of the project stages shifted as we worked with each practice. Overall, the approach was one of flexibility and adaptability, providing tailored support depending on the practice baseline level of hepatitis C knowledge, capacity within the team, and confidence with their medical software. So the pilot project recruited 27 sites, including 13 urban sites, 3 sites in regional centres, 9 in rural settings, 1 remote and 1 very remote. Enrolled practices were located across New South Wales, Victoria, Western Australia and ACT, and included Aboriginal community controlled health organisations and general practices. The principal point of contact was varied across the practices, with 39% being general practitioners, 33% practice managers, 22% registered or practice nurses, and 11% nurse practitioners. So participants reported high levels of satisfaction with project resources and support, particularly the tailored support, however suggested improvements centred on a preference for more directive resources. The PHNs we've linked in with and the subsequent ASHM practice PHN collaborations formed were integral to its success. The role of the PHN has been varied from providing support with data intelligence and local knowledge sharing to the updating of health pathways and resource support. A whole of practice team building approach has also been a key strength and has shown potential for Beyond the C to support laying the framework for long-term practice capacity building. Challenges identified in the evaluation were largely centred around limitations and functionality of the different medical software systems and data extraction tools, the lack of knowledge and understanding in some practices of hepatitis C serology and different tests for hepatitis C, and the quality and integrity of practice data. Resourcing and managing competing demands for this type of work in a busy general practice setting, not to mention the additional demands on general practices throughout the pandemic. So as we move into the implementation phase, we'll be recruiting up to 150 practices. So the challenge for us has been to retain and build on the strengths of the project, such as flexible, tailored support and regional collaborations, while building the program to be delivered on a larger scale. To do this, we've developed a regional framework approach to engage local stakeholders such as PHNs and local health districts early to provide practices with support with a comprehensive and tailored regional support network. So the program takes into account the variable baseline knowledge of practices in relation to hepatitis C and quality improvement, and we've created a hub of resources which are mapped to simplified program phases. Program resources include QI and data templates, which allow practices to self-direct themselves through the program if they have high baseline knowledge and confidence, or access tailored virtual support from our practice nurse advisors if more intensive support is needed. Practices can also complete the minimum data searches, which focus on identifying people who have been lost to follow-up across the care cascade, or take a more advanced dive into their data to identify people who may be at risk of hepatitis C and haven't been tested yet. So continuing the whole of practice approach and acknowledging the diversity of practice leads, the program outlines the roles associated with the project and provides each role with the resources and support to facilitate success associated with their role. This extends to regional support networks. And one suggestion from a local collaborator was to leverage the PHN practice liaisons to be practice champions, particularly for more smaller practices with less capacity. So I'm happy to report that Beyond the Sea is ready to launch and provides enrolled practices with numerous benefits. So supporting the supported learning to develop case finding skills and processes and increased capacity for continuous quality improvement. These are transferable skills that can be used across multiple disease areas. Participating practices receive an auxiliary payment of $1,500 for completing the project cycle, and the program's aligned with the Department of Health QI PIT program. Participants also have access to a suite of resources and individual support from a practice nurse advisor. So this quote is from a participating practice from the pilot program. And when there is a treatment available that clears the hepatitis C virus and people don't get the awful consequences 20 years later of liver cancer, it's very rewarding to treat. And I think this quote really summarizes the broader reach of what we're doing and the real impacts we can have on people's lives. So thank you. If you'd like to find out more about Beyond the Sea, their details are up on the screen. And I think I'm handing over to Greg.
Thanks very much. And I'll try and whiz through this pretty quickly so we can have some time for questions. But what I'm trying to do is just give you some recent sort of data to provide some progress in terms of Hep C elimination, then talk about what are the key sort of strategies going forward. So elimination progress, it's been a bit of a moving elimination targets, particularly from the WHO level, so I'll talk about those. Key populations to focus on, broadening beyond hepatitis C elimination. I think we do have the potential to really look beyond just the elimination of Hep C. In terms of moving targets, WHO initially had targets that were set in terms of 2030 elimination, both in terms of service targets, in terms of testing and diagnosis, and impact targets, such as reduction in incidence of new infections and mortality, 80% and 65% respectively reductions by 2030. There has been a proposal to change those targets to what we call more sort of population-based targets. And one of the key reasons for this is many countries don't have good 2015 data in terms of comparative data to look at those relative trends in terms of the key impact targets. So the proposal is to move to population-based targets. So in terms of incidence of new infections, that would be less than 5 per 100,000 population. Importantly, there is a specific target for people who inject drug, populations of less than 2 per 100 person years, so 2% annual risk of infection. And on the mortality side, it's less than 2 per 100,000 population. So there's discussion now about whether we would shift to that at the global level, and also a discussion obviously in the context of developing targets for the new Australian National Hepatitis C strategy, and a great stakeholder workshop that was led by Hepatitis Australia recently to address those issues. Many of you have seen this slide in different iterations that are presented. You can't sort of miss the rapidly declining treatment numbers after the amazing increase in 2016. We've started to do a bit of work around retreatment. So about 7% of people who've been treated with DA therapy have had at least a second course of therapy, and I'll show you some data shortly. But one of the other, I suppose, top line findings is if we add those that received DA therapy prior to March 2016, we're at around 100,000 people in Australia that have been treated with these transformative new therapies. So a pretty incredible sort of milestone. In terms of the analyses that we've done as far as retreatment goes, this is the overall treatment numbers coming down, and in the dotted line is the number of retreatment events. So just to enlarge that, you can see this increasing number of retreatment events as you would anticipate. Obviously, no one can be treated up unless they've had their first line therapy, so it's clearly going to increase once we see cases of virological failure and also cases of reinfection. One of the PhD students in our program, Joanne Carson, has been leading some work looking at trying to distinguish retreatment for virological failure from retreatment for reinfection, and this is the outcomes from her machine learning based models. So you can see in terms of retreatment for virological failure, an increase in a bit of a dip, and then once we got the access to the triple combination salvage therapy, a big increase in the latter part of 2018 into 2019, and a progressive decline, consistent, I think, with lower numbers of people being treated in terms of their first line therapy. This is the retreatment numbers for reinfection. They've continued to increase and just started to sort of plateau off maybe a slight sort of decline. It'll be really interesting to follow this over the next sort of couple of years. So around about half of our retreatments we estimate for reinfection, about half for virological failure. There are people that get retreated second, sometimes even a third or beyond courses, which is an important component of our unrestricted access to DA therapy. So these are the total numbers of retreatments for virological failure and total numbers of retreatment for reinfections. In terms of our model, we're in the midst of potentially changing some of the model variables, but I just wanted to give you some outputs as far as coverage at 2018 and then our estimated coverage by the end of this year. So based on the model, at least, we would expect about a 40% reduction in incidence of new infections, about a 40% reduction in liver-related mortality, treatment coverage of around a half, and diagnosis by antibody to still under 80%, and RNA diagnosis. Remember, this is of the population currently that are having chronic hepatitis C in terms of the diagnosed proportion. So 58%. So there's still a lot of work to do there, clearly. Really nice data, as always, from the annual Needle and Syringe Program survey led by Jenny Iverson and Lisa Ma here at the Kirby, tracking both treatment coverage, which is above 60% now ever treated. The large, if not the vast majority of these people treated in the pre-DA era, if they'd failed treatment, they would have been retreated with DA therapy. So this is pretty similar to what you would expect the DA therapy coverage to have been among people currently injecting who participated in the Needle and Syringe Program survey. Again, incredibly encouraging reductions in both antibody-based prevalence from over 50% down to under 40%, and RNA prevalence. Although you can see here that the RNA prevalence reduction has really bottomed out, so to speak, at 16%. So what we need to do, and whether this is a COVID effect or other factors are involved, we need to continue to drive this RNA prevalence down. If we can get it down to preferably less than 5%, you would imagine transmission would be markedly reduced, both first infections and reinfections, if we can drive this RNA prevalence down and reduce the sort of reservoir of infection. Jenny and Lisa have also led work that's looked at reinfections in those people that have participated in more than one of the annual Needle and Syringe Program surveys, so they can identify people that have participated in multiple surveys. So when they looked at the incidence of new infections, not reinfections, incidence of new infections, so 13.6 per 100 person years in the pre-DA era, and that reducing by more than half down to 5.4 per 100 person years in the DA era. So almost a 60% reduction. Remember, our model had shown we'd estimated about a 40% reduction, but this data, in fact, estimates a larger reduction in incidence of initial infection. Data also from the Access database reported in the Kirby Burnet Elimination report shows, again, a very similar sort of pattern. So a really nice reduction following 2016 and would be consistent with the reduction that we see in the repeat participants in the annual Needle and Syringe Program survey. So sort of more confirmatory evidence. This is from people attending primary care clinics that have a higher caseload of people who inject drugs. We've also used the younger hepatitis C notifications, so the national notifications, to look at sort of trends. So these are the 15 to 24-year-old age group notifications, looking at trends in monthly notifications. And even though many of these notified cases will be cases that have been infected some years before, by focusing on the younger age group, you should get a better evaluation of recent trends in transmission. And you can see this nice sort of reduction in notifications during 2020 and 2021. Again, this could be partly dependent on testing, although testing dipped a little bit in early 2020 and then recovered somewhat in terms of antibody-based testing. So I don't think it's due to just a testing fall off during the COVID era. Looking at advanced disease, and this is through our New South Wales data linkage project, really encouraging reductions in liver failure, so admissions for decompensated cirrhosis. We've stopped an increasing number of admissions for liver cancer. We'd like to get that to trend down obviously further, and trends in terms of liver-related deaths, again, looking encouraging. I just wanted to sort of look at the model that we've been using and talk about one sort of potential change to the model which may have sort of implications. So we factor in the treatment numbers up until the known treatment numbers, then we put in the estimated numbers that we believe in 2022 and beyond under different scenarios. So we keep appearing to be lowering the treatment numbers, unfortunately, for the intermediate scenario. And you can see that in the intermediate scenario, we continue at about 6,500 people treated per year, but that may be less this year and beyond, hopefully not. Not too sure about increase in treatment, it'd be nice to see it, but we focus a lot on what we believe is the most likely, so the intermediate scenario. But just in terms of the model, our model has utilised a spontaneous clearance rate. So the model incorporates Hep C notifications. The vast majority of those are antibody-based, and an estimate of the undiagnosed proportion on top of that. And then we have to clearly look at the number of people that would have cleared the virus spontaneously. Clearly, those people don't need to be treated. Estimate the number of people with chronic Hep C infection. We have been using a figure of 28%, and that gives us a treatment coverage at the end of 2021 of around about a half. So 48% we estimate would have been treated of those that would be treatment eligible, so have chronic infection. Many of those not yet diagnosed clearly. Now, I just wanted to put together a little bit of other treatment data to see whether that 48% appears to sort of stack up with other data sets. If you look at the annual needle and syringe program survey, remember that is people that currently inject. That's looking at a figure of around about 60%. The Ethos Engage cohort that Jason leads clearly is a selected sample of people in drug treatment needle syringe program surveys who are participating in that study, and it has a sort of intervention component with the point of care RNA testing and linkage to care. So I don't think treatment coverage is anywhere near 82%, but just to highlight that's sort of the best case scenario, I suppose, in terms of the study. The emergency department screening study, this is led by Miriam Levy at Liverpool Hospital, screened around about 5,000 people for hepatitis C with an opt-out sort of methodology. So the vast majority of people coming to emergency department, they focused on two groups, people from an Indigenous ethnicity identification, and also people born overseas. So they didn't target people who had a history of injecting. And in terms of their cascade of care estimate, it was 60% of people had been treated. This was done in late 2018 and early 2019. So looking at the available data that we have, it'd be great to have further sort of data sets. I do believe that the 48% is probably an underestimate of overall treatment coverage. If we increase our spontaneous clearance rate to 36%, consistent with a recent meta-analysis of spontaneous clearance, that changes the treatment coverage somewhat. It doesn't markedly change it, but it brings it up to 56%, which I think is probably closer to the truth. Now, the spontaneous clearance rate is one way to adjust the model. The other potential thing we're looking at is whether we have a significant proportion of notifications that are duplicate notifications across jurisdictional boundaries. So that would also impact on the model. So look, this is I suppose a moving feast. Some people are frustrated by this. I can completely understand that. We'd be happy to have sort of feedback on this, but it's something that we need to continue to focus on to see if we have improved data to incorporate that into our models. Okay, based on that modeling, this is how we would expect the elimination progress under the different scenarios. So in terms of incidence of hepatitis C, under the intermediate scenarios, we actually don't quite get to the 80% reduction, and we don't quite get to the less than 5 per 100,000 population. So that means we've got to increase our efforts, even under this change in the modelling process. In terms of our liver-related mortality, we would remain under the 2 per 100,000 population. We're at about that at the moment, with some slight further reduction through to 2030. And this is where we would end up in terms of elimination under the intermediate scenario. So we would have a 74% reduction in incidence of new infections, nowhere near the 65% reduction in liver-related mortality. It's very difficult for Australia to achieve that because of the fact that we were increasing our liver-related deaths in 2015 prior to DA therapy, but we would achieve the potentially revised target of less than 2 per 100,000 population. Okay, in terms of key populations, clearly we need to focus. I think there's been a lot of discussion about non-marginalised populations and how much Hep C is within those populations. I still believe that the majority, if not the large majority, of the remaining people we need to engage with and link to care are in marginalised populations. Clearly, people who inject drugs, particularly those with more frequent injecting, we know that the remaining Hep C active infection prevalence is higher in those that have more frequent injecting. They're clearly more important to engage and link to care and treatment in terms of the impact on transmission. Aboriginal and Torres Strait Islander people, particularly younger people who inject, people who are incarcerated, other subpopulations, mental health and unstable, housing populations, and older populations, particularly those late diagnosed. So there is about a 15% proportion of people that present with liver failure or liver cancer and are only diagnosed at that time or within the last 2 years. So these are what we call late diagnoses. And I think we need strategies to really reduce that late diagnosis proportion. So what should we do? Jason's talked a lot about the rollout of point of care and other innovative Hep C screening strategies, clearly important. And I think that focus, such as the Combi Clinic, amazing work with intensive screening, leakage to care in high-risk populations, the so-called sort of blitz type programs, I think could be really valuable. Ben Cowie's group at the Doherty has been leading some work in the HepLogic project, looking at using electronic health records and pathology available results to construct a sort of APRI score. So APRI is AST platelet ratio index. So as long as you've got AST and platelet available, you can estimate the APRI score. And those that have higher APRI scores, particularly if they're above 2, but also potentially above 1, are much more likely to have underlying cirrhosis. So it may be that you could use those scores in people that had pathology ordered to increase Hep B, Hep C screening, and therefore reduce the issue that I've talked about in terms of late diagnosis of decompensated cirrhosis and liver cancer. Clearly continued and potentially enhanced hepatitis and drug user community involvement is important, and dedicated funding for monitoring progress, a little bit self-serving, although there are other groups obviously involved in monitoring Hep C elimination progress. I just wanted to highlight this in terms of the role of nurse practitioners. We're trying to get better data on this, but it's certainly a group that's contributed more in terms of the treatment numbers proportionally over recent years, and we'd like to sort of work with the nurse practitioners to optimise that data further. We believe that a significant number and potentially a significant proportion of this group of unknown prescribers are actually nurse practitioner-based prescriptions. I just wanted to finish a little bit beyond like Hep C elimination. I think that we're all very invested in trying to achieve elimination, to reduce incidence of new infections and reduce advanced liver disease burden and liver-related deaths. But I think we have the opportunity to really use this platform to improve public health that are beyond Hep C elimination. So what do I mean by that? I think we have a platform for broader drug user health and human rights, strategies to reduce stigma and discrimination, which may pertain to hepatitis C, but are also clearly broader than that. Expanded access to harm reduction, particularly in prison, is something I think has an impact, obviously, on Hep C elimination, but is a much more important issue beyond just the elimination of hepatitis C. Drug law reform and decriminalisation, easy to sort of write in one line, pretty hard to sort of get traction on, but I think we do need to continue to advocate for. And I think we all have a role in terms of advocacy and to try and improve the lives of the many people that are living with hepatitis C or have lived with hepatitis C, who remain some of the most marginalised and vulnerable individuals in our community. So thanks very much.
Excellent. Thanks so much, Greg. And just thanks so much to all the speakers. You know, it was really amazing presentations, and just really nice to show the sort of partnerships that are ongoing and collaborations. I might take it to Emily and Carrie. Really keen to sort of understand, you know, if you have any further thoughts around what do we need to do around increased health promotion efforts around enhancing, sort of finding those people, testing, treating people living with HCV. You talked about your sort of programs, which is fantastic. What's next? And again, you know, Emily, if you want to add on this, when you're talking about, you know, you guys have done an amazing job with the It's Your Right campaign. It's great to see, again, what's next for you on that. So yeah, if maybe both of you want to have a comment.
Thanks, Jason. So what's next? I think we're learning a lot through the rollout of the It's Your Right campaign. And I wanted to reflect that it's a 3-month burst of intense activities. So we will learn and we will evaluate It's Your Right. But I think if you look at any health promotion campaign that's been effective, and you might want to compare it to recent bowel screening campaigns that you see and hear on the radio and TV, or there's a great campaign, Drama Down Under, which focuses on HIV and sexual health testing in Victoria. That's been running, I think, since 2008. So any health promotion campaign that has a communication element to it needs to be repeated for it to gain in its effectiveness. So what's next? I would love to see an ongoing element of rolling out the It's Your Right campaign, particularly if we find from an evaluation that has effective components to it. We don't want to leave people behind without knowing about the cure for Hep C, without knowing that they can get treated again and again, or that they can get treated while they're using drugs. So I think that repeated campaign rollout is important. And I think also too that each rollout will be refined based on our audiences. You know, Greg just noted who we should be focusing on, and we'd always have to go back to community, whether it's people, Aboriginal young people would have to co-design and refine our campaign messages for that audience. So I think there's lots of opportunity to take it further. There might be different channels. We've used heavily certain channels for our advertising, so buses, local shopping centres, train stations, washrooms in pubs and local shopping centres, but we might find that we can also refine that to reach people in post-release services or mental health services. So lots of work to be done. So I'll hand over to Carrie now for her reflections too.
Carrie, your thoughts? And then the other thing, just Carrie, if you could touch on when you speak, is just, you know, we've talked a lot about the need to think outside the box for people not accessing services around testing and just the importance of patient choice. So if you could just touch as well on what you think around, you know, what do we need to do to better understand who provides testing, settings where testing is offered, and what types of tests people receive?
Yeah, great. Thank you. And what a fantastic group of presentations and activity that's happening. I guess one of the things, to kind of Emily's point, it is important that we're talking to different communities in different ways that's appropriate to them over a long period of time. So, you know, I'm really thoughtful, I think, about all the campaign work, for example, that's happened, for example, in the tobacco space, and how much I know it's a different nature of a problem, but the kind of socializing that's happened in the broader community, where messages have been able to be refined over time and adapted to changing circumstances. And it's so great right now that we've got multiple campaigns happening for different communities in different spaces. Hot off the heels of World Hepatitis Day will be the launch of something called Australia's Biggest Quiz, which is an activation as part of the Ending Hepatitis C campaign, which is going into regional areas and looking to kind of activate and engage with people that we may have kind of lost along the way. So kind of the group of people who, may have been diagnosed 20 years ago, might not know that there's a cure anymore, that we might have lost, that might be, for example, in regional areas like Ballarat or Bundaberg, and might not have access to some of the messaging. So part of that is also, I guess, looking at also culturally and linguistically diverse communities and different understandings of health, and how can we, I guess, socialize and get communities kind of activated. Because in some of the work that we've been doing, what we found is that there's a very low awareness of hepatitis C, and it's low to none, and same with cure. Whereas some other communities have really good exposure to and access to services. So I think what this highlights is a kind of multi-pronged response, and it's not one or the other, it's lots of things in lots of different spaces and responding to that. And I guess this goes to our challenge. Stu, you talked about this at the beginning. The closer we get, the harder it's going to get. And that all the time we're going to need to be agile and kind of pivoting to be able to do that. But critically, what the hepatitis space needs is resources to be able to rely on, to be able to do that adaptation work, and that those resources can be, I guess, in place in a stable kind of way. Because I think that's one of the challenges we've got with the stop and start funding that happens, that it makes it really hard for people to plan, and people start to forge relationships in communities, and then they've got to stop. So that's, I think, a critical ingredient across the board.
That's awesome. Thanks, Carrie. I agree. I might throw to Stu. Like, I'm conscious of time, and I'm sorry, maybe we won't get around to everybody saying something in the panel discussion, but I'm just, Stu, I just sort of curious if you could reflect on, what would be 2 to 3 key achievements that you would like to see over the next couple of years to help set a strong foundation for achieving HCV elimination? And that's one question. And the second question is, what would you like to see from researchers, providers in the affected community to help facilitate driving forward policy in the Hep C space moving forward? Oh, you're just on mute, Stu. Sorry.
Whoops. Thanks, Jason. I might answer them in the reversed order. I think in terms of researchers, affected community, it's the continued engagement that we've had, and that continued enthusiasm and willingness to work with government. I think that probably will help underpin things. And in the 1 minute remaining, what will be the 2 or 3 big achievements in the next little while? Immediately, for me, it will be the next iteration of the strategies, that they're as strong as they possibly can be to drive us towards our elimination goals in 2030. Throughout all of the presentations today, there's been, I think there's a need to look at the different testing modalities that we have available in Australia, and to try and get more options available so that something is fit for purpose for everyone who needs to be tested to find out their diagnosis. And the other really important thing, I think, is sustainability, and everyone has mentioned that. And as the government representative here, that's the departmental representative. It's something that I acknowledge, and the stopping and starting, or the upping and downing of funding probably isn't. Is less than ideal to be able to keep driving us. So finding ways to make things sustainable, and that is through for all of the pillars of the 50,000 project that we need to build that sustainability in. And I was heartened by Greg's last slide. And what about beyond elimination? Looking at the health and human rights of people in prison, looking at the stigma and discrimination. Whilst yes, it will impact hepatitis C, it will impact lives more greatly than that also.
No, that's awesome. Thanks, Stu. All right, well, look, time is upon us. As much apologies, Shelley and Greg, for no questions. You get out easy. But yeah, unless there's something that either of you has a burning desire to say or reflect on.
Just one final thought. In my rush to start the presentation, I didn't acknowledge the Indigenous people's lands that I'm on, the Bejigal people. Just to make the final sort of point, I think following on from our report last year in terms of hepatitis C elimination in Aboriginal and Torres Strait Islander people, I think we really do have a commitment to close those gaps on diagnosis, on treatment. And if we're thinking about beyond hepatitis C, there's a lot to do beyond hepatitis C for Indigenous Australians.
What a great point to end on, and thinking about the equity lens, and that we're not going to achieve hepatitis C elimination until all populations have reached the WHO elimination target. So that's great, Greg. Thanks for mentioning that. And I think that's a mantra we should be sort of keeping in our back pocket as we move forward. Not in our back pocket, at the forefront of our minds moving forward. And so, yeah, thanks again to all the speakers. Really appreciate your time. We had a great showing, almost 200 people. So yeah, really appreciate everyone's time, and happy rest of the World Hepatitis Week festivities. And yeah, thanks everyone. Have a good day.
Thanks everyone.
Thanks, Phil.
Thank you.